First of all, I'd like to thank Professor Wei Xiang for inviting the honorable guests, Professor Schaff, Professor Mestres, and Professor Quintana, as well as the honorable members of our domestic colleagues. Today, I would like to report to you our Zhejiang Provincial People's Hospital's single-center experience in using a small infra-axillary incision to do this complex modified Morrow procedure via the aortic approach. I won't mention the background, which has already been covered a lot. When we consider the left ventricular outflow tract, it is like we're looking at a corridor made up of two walls. On one side, there's the interventricular septum, and on the other, we've got the mitral valve and its attachments. In this setup, if there's any obstruction, it's quite possible that it could be originating from either one of these walls, or in some cases, it might even be a combination of both. That's the way I see it from my own perspective. We believe multiple factors contribute to outflow tract obstruction. The most common one is interventricular septal thickening, as seen in many patients. However, there is extensive literature in this field which suggests that septal hypertrophy might not be the only and single cause of obstruction. For instance, in hypertrophic cardiomyopathy, besides the obstructive type, there's a non-obstructive type. Many non-obstructive patients have a septum thicker than 3 centimeters, but they don't have outflow tract obstruction. So if septum is the only cause of obstruction, why are some patients with thick septum not obstructed? In the second scenario, many patients with normal or mildly thickened interventricular septum have severe outflow tract obstruction. Detailed echocardiography and MRI reveal that mitral valve structures, leaflets, papillary muscles, secondary chordae, and abnormal muscle bundles can all contribute to this obstruction. This morning, Professor Schaff discussed a patient whose interventricular septum was only 12 millimeter thick. Using his expertise, he could reduce it to 8 millimeters and then successfully relieve the outflow tract obstruction. However, most of us do not have Professor Schaff's legendary experience, so we might need a more comprehensive method for handling such kind of patients. Okay, the third point. As cardiac surgeons, I believe most of us perform a lot of mitral valve repairs. We know that in patients with challenging anatomy, improper techniques can induce iatrogenic SAM and outflow tract obstruction, even in those who have no septal thickness or cardiomyopathy. These patients actually have problems in their LV structures. I think outflow tract obstruction isn't limited to cardiomyopathy with septal hypertrophy. As Professor Wang Shuiyun noted, even non-cardiomyopathy ICU patients, when facing dehydration, infection, or septic shock, might develop alveolar obstruction. So it's not that simple. So I've been thinking about patients who have hypertrophic left ventricular outflow tract obstruction. It seems like they might have problems not just with the interventricular septum, but also with the mitral valve. When it comes to treating this, do you think surgeons and cardiologists should just concentrate on thinning the septum, or should they also look at fixing the mitral valve as well? This is a big topic of discussion around the world, but not so much in China, where doctors mostly focus on the septum. I wonder if there's some historical reason why Chinese doctors lean this way. Anyway, I'm just sharing what I think about this whole thing, and I'd really appreciate your thoughts and any corrections you might have. If we aim to completely eliminate left ventricular outflow tract obstruction by focusing on thinning the septum alone, could excessive myectomy lead to some problems? I think the answer should be yes, and I will present some evidence. The first issue is we might accidentally perforate the interventricular septum, which is difficult to repair. This, as we know, is a catastrophic complication for the patient, potentially making them die on table. Secondly, if there's no perforation but the interventricular septum is left excessively thin, could this lead to long-term damage to the patient's cardiac function? I believe some of us might have experienced such lessons. A large international study here indicates that many post-surgical patients, through extensive long-term follow-up, exhibit a decline in cardiac function over time. The third point, hypertrophic cardiomyopathy, a genetic and progressive disease, involves continuous myocardial fibrosis. Given that myocardial cells are finite and non-regenerative, excessive surgical removal, coupled with fibrosis in the remaining cells, might lead to a transition from hypertrophic to dilated cardiomyopathy, ultimately resulting in heart failure. These aspects require further clarification. Beyond the interventricular septum and mitral valve, we've also observed that other factors contribute to left ventricular outflow tract obstruction. As we learned from Professor Schaff, many patients have abnormal intraventricular connections that contribute to this obstruction. These aberrant fibrous and muscular connections can directly link the mitral valve to the septum. Therefore, without precise excision of these connections, it's impossible to completely alleviate the outflow tract obstruction. Professor Wang Shuyun just mentioned that an abnormal muscle bundle extending from the base to the apex near the anterior papillary muscle can significantly impact the obstruction and even affect the patient's diastolic function. This paper shows many patients have such a muscle bundle, and here the images demonstrate how those muscle bundles pull the basal part of the interventricular septum towards the apex, or even tethering the anterior leaflet of the mitral valve. Without meticulous treatment of these complex muscle bundles, simple intervention on the septum alone might not be sufficient to solve the obstruction problem. And this is a recent patient I just operated on, where you can see a notably thick abnormal muscle bundle in the LV. This bundle contributes to the obstruction, and the picture on the right showed the surgically removed specimen. In summary, our center adopts a more integrated approach to treat each patient's outflow tract obstruction individually. This is in tribute to Dr. Quintana, with the image from his influential paper, which has a significant impact on us. This image in the middle illustrates the importance of the secondary chordae tendineae. These secondary chords of the mitral valve play a role in the development of outflow tract obstruction. As shown in patients with outflow tract obstruction, simply removing the septum muscle without cutting the secondary chordae may prevent the mitral valve's anterior leaflet from adequately approaching the posterior annulus during systole. In this scenario, the left ventricular outflow tract is still not perfect. By addressing the septum and secondary chordae simultaneously, a better outflow tract structure is achievable. The picture on the right shows treating the abnormal papillary muscle insertion into the anterior mitral valve leaflet. While we've acknowledged the excellent outcomes of surgery as the gold standard, many patients are reluctant to undergo our traditional open heart surgery. This compels us as surgeons to develop minimally invasive techniques. Our center's journey with minimally invasive surgery progressed like this. Since January 2019, we have been performing Morrow procedure via a thoracoscopic assisted approach through the mitral valve. Initially, we performed anterior leaflet patching and then switched to direct suturing of the leaflet. After completing over 30 such cases, we changed again due to concerns about complications from potential mitral valve damage. We know that the optimal surgical outcomes are all achieved via the transaortic approach. So we started to develop a minimally invasive technique via the aortic valve. Nowadays, we no longer employ the mitral valve approach for Morrow procedure anymore. Currently, this is the surgical technique we employ at our center. Instead of the traditional median sternotomy, we've adopted an axillary approach, primarily inspired by Professor Joseph Lamelas from Miami, USA. We make a small vertical incision about 4 to 5 centimeters in length in the axilla, typically between the 3rd and 4th intercostal spaces to access the chest. Our method can basically copy almost all of the techniques of median sternotomy via the transaortic approach, including sufficient resection of the septum, cutting the secondary chordae, along with addressing accompanying lesions. I'll present more on this later, similar to what Professor Quintana discussed this morning, focusing on the treatment of various associated pathologies. During the operation, we will directly measure postoperative pressure gradients. Before closing the aortotomy incision, we insert a catheter into the left ventricle to monitor its pressure, a technique learned from Mayo Clinic. We conduct this real-time pressure measurement for every surgical case. Initially, we place the pressure catheter through the ascending aorta, but later, we switch to inserting it via the right upper pulmonary vein. passing it through the mitral valve directly into the left ventricle for measurement. Furthermore, in our center, most patients undergoing minimally invasive Morrow procedure can be extubated on the operating table immediately. This is so-called ultra-fast track anesthesia. These patients typically spend one night in the ICU for observation and are often transferred out the following day. Our early experience with this approach has also been published,